All right, so we're going to do musculoskeletal injuries, and here we go. Here's a great picture. You don't have to learn this. I just liked it, so I put it in. Okay, this is the bones. See, radius ulnar, femur, tib fib. It's a skeleton made out of the names of the bones. It's good, right? All right, let's go. All right, let's do a quick recap on some anatomy, right, that we need to know. So skeletal system, function of the skeletal system, well, it provides us with shape, it provides a place for muscles to sit, it produces red blood cells. Right? There is a tremendous blood supply within the center of the bones, and as medics, we utilize that. We will drill into a patient's bone, I call it Black and Decker medicine, and I just drill right in so I can get very, very fast access to the circulatory blood supply system.
IO?
So it's really quick. It's called IO, yeah. So that's your skeleton. All right, if you didn't know this by now, get out. Because we've done this numerous times. All right? You need to know the 33 vertebrae. You need to know them. You need to know the 5 divisions. And you need to know that they are divided into 7, 12, 5, 5, 4.
5 and 4, really one.
Just learn these numbers. Learn these numbers, okay? 33 vertebrae. All right. We should know by now that the arms are made of 1 large bone called the humerus, 2 smaller bones called the radius and the ulna. We need to know that the radius is which? Is it lateral or medial?
Lateral.
Always lateral, always the most lateral bone, right? The thumb, most lateral part of the body. Pelvic girdle, made of the ilium, the ischium. I didn't go make you really get into that. We will talk about the ischium in the skill night. And the legs, these bones you must know. Long bone from the pelvis down to the knee is called the femur. Very good. The knee cap itself is the patella. Then we have 2 bones called the tib fib. Tib fib we call it for short. Tibia and fibula. And then we have...
Which one's the front one? Tibia's in the front?
You mean radial or lateral?
medial or lateral.
No, it's not even medial or lateral. It's
Anterior.
anterior or posterior.
No, it's the tibia is more medial. The fibula is more lateral. Okay. The calcaneus, I mentioned that bone once. That is the heel bone. It is the largest of the 7 tarsals. You should know that bone. And then again, the metatarsals and the phalanges we don't need to worry about in EMT school. Muscle.
I was only 14 phalanges. Quick.
Count. On each hand or foot. 3 in each finger, 2 in each thumb. 3 times 4 is 12, plus 2, 14.
I thought you meant for like the whole body.
Each hand or foot.
That's
Muscle. Okay, that's skeleton in a nutshell. Right? Muscle. There are 3 types of muscle. This is all recap. We've done this. We know this. We've read this. We've studied it. There are 3 types of muscle found in the body. The first one is skeletal muscle, right? What did we say about that? It is voluntary. Good, we know this. Good, good, good. Second type of muscle is known as smooth muscle or involuntary. We don't have to think to make ourselves digest the banana and the apple, right? We don't have to think about it. We don't have to eat either. Good. The third type of muscle that we find is only found in one place. And that is the heart muscle. We've given it a name now. The myocardium. Very good. You must know these 3 types of muscles. You need to know where they're found. All right, some new words, some new stuff. Here we go. Right? Because we've got to learn more stuff, right? course. Fantastic. Let's learn about tendons. Let's learn about tendons. I want to draw something on the board. So a tendon, hold on, a tendon is an extension of a muscle, right? Listen very carefully to the wording. A tendon is the extension of a muscle, and it joins the muscle to the bone. So it actually fuses and joins the muscle to the bone. As far as you're concerned, for EMS and EMT studies, a tendon is equal to a muscle, and a muscle is equal to a tendon. However, the tendons are actually found at the
Meeting.
above the joints, okay? Top and bottom of longer bones, all right? And they join the muscle to the bone. One way to remember this, which we came up with on one particular class, so just go over here to write it, is you are becoming something called an EMTB. Okay, that is the certification that you're working on. It stands for Emergency Medical Technician Basic, right? It also stands for every muscle, tendon, bone.
I like it.
So that's the verb.
Okay? So that's just to help you remember, because they will test you on this. You've got to know what a tendon is. And also the problems that we're going to run into at the muscle and tendon level.
So do
Okay?
you know that it connects muscles to the bone?
Yeah. All right, next is a ligament. Ligament. Ligaments are only found at joints. Okay? Ligaments connect bone to bone. So in this example here, you have a bone here, you have a ligament, and then you have bone here. Right? Same thing here. Bone to bone. Bones are connected at joints by ligaments.
ACL?
Right, we're not getting into any specific ones. Let's just keep it really simple. Tendons, ligaments, cartilage, you don't really need to know much about it, but I put it here. It's just the cushioning between the bones. Don't worry about it too much. Learn tendons and ligaments. Know the difference, know what they are. Okay. Problems that we're going to occur, that we're going to see. Okay? Fracture. Fracture. Let's do this really simply and understand that the definition of a fracture is a break in the structure of a bone. Okay? What does that mean? What is a fracture? A fracture is a break, and a break is a fracture. And I can tell you from doing this for a couple days that whichever word you pick to tell mom that the reason why we're going to go to the hospital to get an x-ray for little Johnny, if you say, well, we need to make sure it's not fractured, you'll hear something like, oh, but thank God it's not broken. And if you say, well, we're just going to check that nothing's broken, you'll get something like, oh, but you don't think it's fractured, right? Because in the real world, they seem, somehow, America has been convinced that these are two different things. Okay? As far as we're concerned, a break and a fracture are the same thing. Okay? It doesn't matter how severe or how minor, they're all breaks and they're all fractures. Okay? So, if there's a break in the structure of the bone, no matter what it looks like, maybe continuous, maybe discontinuous, doesn't matter, it's a break or a fracture.
Continuous or discontinuous? A full break?
Yeah, or doesn't have to be.
Multiple.
Okay, look at this, green stick fracture, very common in children. See, there's only some part of the bone has actually broken. It's not like that, okay, or like that, okay? You do not know, you're not responsible for learning all the different types of breaks, what they look like, what happened to them. You're not responsible for this.
But to a certain extent, it is important to know that because one can break through the skin and one won't.
Well, we'll get to
We'll see
that.
that.
I didn't get to that yet. That you will know.
Nobody, even if it
Thanks.
doesn't, it can.
Thanks.
Nobody can.
There you go.
Let me talk. I'll answer most of your questions before. Alright?
Oh, see? Right there.
So, two types of fractures. Each one, yeah, just shed light for a second so they can see. Each type of fracture has two names. You should be familiar with both names. Two fractures, each one has two names. Closed fracture or a simple fracture. It's not simple. These can be worse than open fractures. Okay? The only reason why it's called closed or simple is because the skin has not been broken. These can be extremely painful and extremely difficult to fix. They need surgery a lot of the time, pins, plates. It's called an orifice in medicine.
Rods.
Okay? And rods, yeah. So that would be called an orifice. Open reduction internal fixation. That's the medical term for that surgery to fix these. Okay? So, you don't need to know that. You'll not need to know that. Unless a patient tells you they had an orifice and you don't want to be like, what's that? So, knowledge is good. The more knowledge you get, the smarter you are, the better you'll be.
Reduction external fracture.
So again, a closed or a simple fracture is where you do not see the bone protruding through the skin. Clear?
Yeah.
You do not see it. The opposite is an open or also known as a compound fracture. Most EMTs and many medics do not know the difference between these words. Simple, compound, open. I heard guys on the radio say, I have a patient with an open compound fracture. That's the same thing.
Redundant.
So why, yeah, redundancy. All right?
What's the stress? I always thought stress and compound is the same thing. Stress fracture, compound fracture. Going up, huh?
No. An open or a compound fracture is one where you see the bone. Okay? You do not need an x-ray, all right, to diagnose that there is a fracture here, okay? 99% of the time, it will be a closed fracture. You will not know.
Okay.
You go to rule it out, okay?
What is a stress fracture then? Nothing.
Not getting into it, okay? It's not an emergency.
Huh?
Not an emergency. They're closed fractures, all right? That's all you need to know. So, this is what you need to be worried about, all right? Open compound fractures or closed simple fractures. We'll talk about it. We'll understand how we're going to evaluate it, how we're going to see it. Dislocations, okay? So before we get to this, let me just make one thing very clear. A fracture can only happen to a bone. Okay? Simple. Now, a dislocation can only happen at a joint. Remember, a joint doesn't really exist. Okay? It is the articulation, I used a big word for you, of two bones. That is what a joint is. It's something that's been created, okay, to where bones can articulate. So a dislocation is where a joint has been moved beyond its normal range, okay? And now it can't move anywhere. It just hangs, let's say, okay? That's a dislocation. That's all I want to say right now. We'll move on. Sprains and strains. These are words that in America nobody understands the definition of these words. Okay? So EMTs must know the difference. Because you gotta know what you're talking about. Or pretend to know what you're talking about. Okay? Sprains and strains. Okay? Let's start with strains because this one is easy. Strain is spelled S-T. T. T stands for tendon. Tendons are the same as muscles. So what can you strain? Only a muscle or a tendon. Write it down if you don't know this.
Wait, it's stretching the muscle?
It's a strain. Okay? It's it's pulling a tendon or a muscle beyond its normal point. The other word is a sprain, and that can only occur, you can only sprain what? A ligament. You can only sprain a ligament. You cannot sprain your leg, your foot, okay?
Ankle.
You're right. You can sprain a ligament in your ankle, okay? Because, and it really, where did I say we find ligaments? Only at joints. So you can't sprain your forearm because there won't be any ligament there holding the bones together. So a sprain will have to be at a joint and needs to be a ligament. So if someone says, I sprained my ankle, there is some truth to that. Because an ankle is a joint. So that's possible. You could sprain your knee, your elbow, these things, your shoulder, these things could be sprained because there are ligaments there. Wrist is also a joint, yeah. Okay? So, listen, I'm going to repeat this. I need you to study this. There are 4 body parts. There are bones, there are joints, there are muscles and tendons, and then there are ligaments. Each one has its own injuries that accompany it. Bones get fractured, joints get dislocated, tendons and muscles get strained. You need the T. And ligaments get sprained. Remember this.
What was the second one?
Joints, muscles.
Get dislocated.
Wait, what? This is gonna move. No, it's not.
Joints get what?
It should
Joints
move.
get dislocated.
Oh, there we go.
Wow.
Ligaments?
That was good for the 80s.
Yeah.
Is that to make us dizzy?
I missed it. Do it again.
Oh,
Sprain.
Oh, now look what you did.
can't click it twice.
It won't do it
Skipping
again.
Once a night,
Skipping
that's
the
it.
animation.
The mission is only for one time.
This wasn't included in our.
It's coming.
Okay. Glad that excited you. Okay. So, alright, a lot of words here, so don't worry about them. Listen to me. Listen to me. Doesn't matter what it says there, I'm going to tell you what's important. To know what's going on, unless it's a compound fracture and you see the tibia, sticking up through the skin. But taking that, we will assume that that doesn't happen every day, okay? So, assuming that it's just day-to-day stuff at school, stuff at home, stuff at the job, or whatever it is, right? You cannot diagnose which one of these problems exactly is going on, okay? We need imaging. There's no question about it. Yes, if you see the tibia through the skin, I will even allow you to diagnose that that is a fractured tibia. I don't mind. But in 99% of cases, you won't know. You won't know. I can tell you that when it comes to orthopedic injuries, I always decide with myself what the outcome will be, and I would say that I'm not even batting 50%, okay? I'm not doing well in my pre-hospital diagnosis of orthopedic injuries. There are times when I'm 100% certain that it's broken, and it's not. Times I'm 100% certain that it's not broken, and it was. So, with all that being said, this is the rule. General rule, right? Treat every injury as a fracture. You don't know. You don't know. You don't have an X-ray machine yet in the back of an ambulance in New York City. Okay? And it may need more. It may need CAT scan, it may need MRI. Who knows what it means? But whatever it is, you don't have it in your ambulance. So don't play orthopedist. Even if you were an orthopedist,
He doesn't play.
you would guess just the same like I guess. You may have a better way of guessing, but he's still going to be wrong many, many times till he gets an x-ray. That's just the way it is. This needs imaging.
Even if it's in holiday.
In New York State, they don't even allow in EMS to use the word fracture or break, because that's a diagnosis. To say you have a broken leg, you just made a diagnosis. You can't do that.
EMT can't make a diagnosis?
Right.
So you gotta say.
What do you say, possible fracture, whatever?
No, I'll tell you what you gotta say. They are therefore called this: painful, swollen, deformed extremities. Yeah, that's the politically correct way of saying it. You will see that though on New York State, like exams and things. Painful, swollen, deformed extremities. Let's look at these words and let's try to understand them. Well, painful, most of you are married, so I don't need to explain what that means. Swollen, I know. Okay, you have no idea. Swollen, being in the army doesn't come close. Swollen, I think we can all understand swollen, right? You see something swell up, you see something that looks like a grapefruit sized, something out of part of their anatomy, that's swollen. We can see that. Deformed, you've got to look at both of their extremities. Not look at it compared to yours. Because they may have some quirky deformity on both sides and that's their normal. Alright? So look at both. And if you go, oh, that don't look the same as that one, right? That's deformed. Right? So these are things that we can do, right? We can assess for pain, swelling, deformity, and extremities, arms and legs. So we can do that. So that's what we're going to refer to fractures and breaks. Again, the rest of this basically says, treat all these orthopedic type injuries as fractures. You can't go wrong.
But just don't call it a fracture.
Don't call it a fracture. Right. Alright? Signs and symptoms of musculoskeletal injuries. So, bruising, I'll just talk about some of the real, big ones that you're going to really need to know about. Deformity and angulation. Angulation often means that the arm or the leg is stuck like that in an angle, and they can't move it. Okay, that's called an angulated elbow. Alright, they've done something and they can't straighten it or move it.
What would that,
Same thing with the knee. That would be angulated.
so what would that be as a result of?
Again, you remember what I said here?
Break your femur.
Just treat it as a fracture and...
Treat them all as a fracture.
Let's go with it.
Exposed bone ends. Okay, so that one gives game away, right? If you see exposed bone ends, okay, that's the one I told you. Yeah, you can diagnose that.
What's the second one?
Alright, loss of circulation we'll get to. Loss of motion, we'll talk about this. Swelling and tenderness. Tenderness, what is the definition of tenderness? A very important word in medicine. Tenderness, tender. You need to know this. When you, the practitioner, when you, the EMT, touches a part of their body and they are in pain because you touched, which we call palpated, that's tenderness, okay?
Pain to
So-
palpation. Pain to palpation.
Yes, pain to palpation. That is the definition of tenderness. Pain is them saying, this hurts. That's pain, okay? Tenderness is when you touch it and they go, or you look at their face when you're doing it actually, and if they go like this, that's tenderness, okay?
You skipped the second one of
Okay,
bruises?
what's the second one?
Yeah.
Coupler.
I want to talk about these. Wait, I have much more important stuff to talk about. Stay with the program. loss of circulation. How do you, as EMTs, assess circulation in a patient?
Pulse.
Color?
Very good. The most distal pulse that you can find. Right? What's the most distal pulse in the upper extremities? Radial pulse. Very good. So, if their arm looks like, like that, and you can't feel a radial pulse, then you can say, you can't say it's broken. You can say there's a loss of circulation. That you can say. Okay?
You can say facts.
You can say facts. Right.
Deformity.
Okay? So,
So you always have to do distal to the.
distal to the injury. Always. Okay? We'll show you on skill nights how to get in the lower extremities the two pulses in the feet. Okay? Also. Alright? Anyone remember the names?
Lopez something.
No, that's been.
Femoral is in the groin.
Tibble something.
We're not gonna be doing that.
Tibble nose, tibble.
No.
Tibble something.
Yeah.
Tendon. What? What, the pulse?
Yeah.
Yeah.
It's the tibble something.
It's a diagram.
It's the second word's pedis, P-E-D-I-S.
Okay.
No, I can't read
And
it.
the first word.
Posterior
Posterior
tibialis
Tibialis.
and the dorsalis pedis. We taught you this stuff.
Yes, I studied it.
You need to know this. Okay? Gotta know this stuff. Alright? Good. I want to show you something on the board.
Fetus with a D.
Wait, I copyrighted it, and please do not say that.
I want to show you something on the board.
Now that you're up.
So,
That's too quick to fire.
and get rid of the artery from last night.
Systolic?
So, there are three things that on every one of these patients we need to assess for. Okay? The first one, you understood, pulse, right? And remember, it means a distal pulse to the injury. Okay? So that one we call P. Easy, right? Pulse. Now, there's two more things we need to assess for. One is motion. Can they move part of the body distal to the injury? All right? And with the arm and the hand will always be the fingers, and with the leg and the foot it will be the toes. So what you need to do is ask them to wiggle their fingers. And we're testing for motion. So this one we call M.
This one's S.
The last thing we need to assess for is sensory.
Nailed it.
Sensory.
CMS.
Can they feel when you touch? Okay, again, distal to the injury. Can you feel when you touch? And you need to block their eyesight. We'll show you how to do it on skill nights. You block their vision and you touch either their pinky or their thumb. Okay? And you ask them, which finger am I touching? Okay? And if they can tell you correctly, then you have sensory. And this is PMS. PMS is a acronym, a Rosh Hashanah, that we're going to use a lot. We're going to test it on every single patient that has any type of orthopedic injury. We're going to test it before we apply a splint and after we apply a splint. And I'll get to splinting in a minute. Hold on. Again, these three things are really important. Circulation. We need to assess for loss of circulation. That's P.
P is
We
what?
need to pulse.
Pulse.
We need to assess for motor and sensation, motor and sensory, and those are actually neurological deficits. Those have nothing to do with blood flow to that particular area of the body. You understand that?
Even the pulse?
No. Pulse is blood flow. pulse.
Motion
Motor and sensory
are
are neurological. So we're testing to see if the brain is able to send messages all the way to the
You're
fingers.
testing the nerves.
And S is?
Sensory.
Sensory.
Can they feel what we're touching? So this is the real PMS. People ask why it's called PMS by women once a month, and the answer to that is that mad cow disease was already taken.
Can you talk distal for a minute?
Can I what?
Can you distal? Well, something is distal. So on what parts of the body, someone cuts their hand. Does the radial pulse is distal?
No, that would be proximal.
Neck is.
It has to be distal
How do
further.
you look at it like this or like this?
Always in the anatomical. Come on, you know
I
that.
do know that.
You do know this.
So this would be
Proximal. It's no good getting a proximal pulse if the deformity is here and they've got a great brachial artery.
Where else are you gonna know
That's
the
not
pulse?
telling you
So what are you
anything.
gonna do if there's a
You got a problem.
Oh, okay. Oh,
But you can do motor.
right.
You can do motor and sensation.
Oh, okay.
What on fingers?
So if
Okay.
you get in the middle of the arm,
Then you do the, then you do the.
brachial.
No.
Radio, always distal.
Oh my
Further away.
God.
Further away.
Splinting.
Injury, pulse.
The way we deal with painful, swollen, deformed extremities, the way we deal with them is by splinting them. We will do an entire night on splinting, and you'll be tested on splinting by New York State. This is something will be ongoing skill throughout the course. From when I teach it, we'll continue to practice it and master how to splint properly. Okay?
Jeff made it seem like it's the hardest of the practical exams.
Well, Jeff is in
The
here.
traction splint.
Oh, Jeff, that's
He got, that's because he got scared once by that guy.
It's the most painful in the world.
All right.
Who's teaching the class?
You don't have to read the book.
Nothing is hard. I'm sure there is somebody out there who became an EMT not as smart as you, that you can think of.
You.
Don't say it out loud. No, that doesn't count. That's me. No one else is an EMT here, okay? Alright, why do we splint? Let's stick to theory rather than practice. We'll get to practice on skill nights, but let's think of reasons for splinting. Well, if it's a closed, simple fracture, we have no idea what's going on inside. If we let them move around and do their regular thing, there may be nerve damage, there may be, tissue damage, all sorts of problems going on, vessels. So, a closed injury could even become an open injury, right? If that bone is allowed to move around. So we splint, it's taken very seriously, we do it properly. We also want to decrease pain. And let me tell you something, it really, really works. There are two ways to decrease pain when somebody has an orthopedic type injury. One is for the EMTs to splint the extremity. Splint it properly. This will decrease the pain. The other one is to call me, and I will give them copious amounts of good stuff, all right? But again, when I get there and the EMTs haven't even attempted to splint the patient, I get a little angry. And you don't want to see me when I'm angry, okay? So do what you're supposed to do, okay? If you need me to give them analgesia, that's my pleasure. I will always do that. Little for them, little for me. We can, I might be, all right? So we can share, that's okay. But you've got to do yours, right? Splint. All right, types of splints. So we, okay. We very rarely use anatomic splints. This is something like wilderness first aid, even general first aid. They'll do anatomic splints. We're going to use soft splints. We're going to use fixation, rigid splints. That's most of our splints. and we're going to learn how to use this guy, which is a traction splint. Okay? So we will learn how to do these. Not a problem. You'll all learn, you'll all get it. All right, lots of words here. I think that I want to summarize what it says here by saying like this. If it doesn't say this, you may just want to take a note. It's really simple. If we're I'm gonna go to the board. We're gonna go to the board. Okay. Now you're gonna learn that I didn't take.
Oh, we were hoping you would leave that at the very. No, just kidding.
What?
And foot.
I didn't get really very far in art in school, so okay. It may not look anything like your.
You started though?
No.
You stuck to math, right?
Yeah. Okay, so here we have typical.
Oh, frog.
No, six
Six fingers? That could be an issue or not?
Alright, so here we have an arm.
Princess Bride.
Deformity.
Okay. Up here we have the shoulder, right? This is the
Join.
Elbow.
elbow. And here we have
Something.
some deformity, some swelling, right?
Pain.
Secondary to whatever situation, whatever happened to our patient. Okay? What do we have here?
Radio pulse.
Wrist.
Wrist, right? So we've got a joint, shoulder, elbow, wrist. So
What's the 6 fingers?
how are we gonna splint this? How are we gonna splint this? Is it really bothering you, the sixth finger?
He's not sure if it's two pinkies or two thumbs.
I'm not too good at art.
It's two middle fingers. That's
I would take
I
wrist.
guess that's my true feeling, right?
Join the joint.
So, what is the rule of splinting? How do we splint? What is the general rule? Theoretically, and then we're going to put it into practice, okay? So the rule is very simple, really. You need to splint the extremity that is affected, right? The affected extremity. What would we call the affected extremity? Forearm, which bones are involved there? Radius and ulnar. Okay, sometimes we write it like this, RU, radius ulnar, okay? Because the words are difficult to spell, right? So radius ulnar, very good. So we need to splint the extremity, the part of the extremity that is affected. Now, we're going to take, before we do anything, we're always going to remember we got to do PSI. And number 2 now is going to be always PMS. Before we start. Why? Why are we doing PMS before we start?
It's like
You know how extreme it is.
noticing.
Okay,
You wanna see the change?
right. You want to see if PMS was check, check, check before, and now you put on a splint, and now one of them is gone. Whose fault?
Yours.
Yours. You put on too tight. So that's the only way you can know.
So you
So,
get PMS, splint PMS?
wait. Number 3 is going to be apply a splint. Now, what is the rule of splinting? The rule of splinting says like this. Number 1 is going to be the affected area. Okay? Number 2 is going to be the joint that is proximal and distal to area. This is the rule for a fracture or a bone injury. Okay? Do you all understand this? What are we splinting?
The elbow on this one.
And the wrist.
And the wrist. Very good.
What is
So we need to splint from here till here. We've got to get the proximal and the distal joint to the affected area. We see the affected area because
Got the swelling.
we see the swelling. We don't need an x-ray to see swelling. Okay? Now, there may not be swelling. It may be tenderness. How do we find out if that it's tender?
Touch it.
Touch it. Or they can tell you, ah, it hurts. Where does it hurt? There. Do we need to touch it? No. They're screaming in pain. That works just as well. So, we need to splint.
Elbow to wrist.
Elbow will be the joint that is proximal, and wrist will be the joint that is distal. Do we have to splint or immobilize the shoulder?
No.
In this case?
No.
No, we don't. You see the general rule? Afterwards, we always do, number 4 will always be again, PMS. Alright, and then 5 we can put TXP,
That's good.
transport. Okay? Now, yes, you can mix in other things into here, calling for ALS, carrying them to the ambulance, yeah, it's all good stuff, but I'm just talking about the actual. Okay, so you get this? Now, what happens if the injury is no longer here, but the injury is now right here?
Because of the shoulder.
A full splint. A full
Oh, it's not full
shoulder
hand.
to, shoulder to wrist.
So what is injured? What are we concerned about? Is it a bone? Is it a joint?
You don't know. You don't know.
We don't know, but they're complaining of pain here, and they're saying, and it's tender there, and there's no swelling anywhere else. So what are we concerned about?
Joint.
A joint, possible dislocation, okay? So all the rules are the same, except for number 3. So I'm gonna go here, so 1, 2, 4, 5 are all identical. Now we're gonna do number 3. This is for a joint. So number 1 is gonna be the area, right? Which is the elbow. Number 2, I was doing Roman.
5 is transport.
Number 2, small Roman. Number 2 is going to be the bone that is proximal and distal to the area. Now, in this case, what am I going to have to splint?
Shoulder to wrist.
The humerus, very good. We can write that in over here. The humerus and
Are you?
the radius ulnar. Very good. That is.
You splint the shoulder also or no?
Do we need to?
Just the bones. Only if the humerus was broken.
Very good. This is the rule of splinting. And we will apply this when I teach you exactly how to do it on skill nights. But again, tonight is for the theory.
So you think basically if it's you break the bone, you go joint to joint. You break the joint, you go bone to bone.
Yes. Exactly.
When you do, let's say it's a shoulder, what do you?
So, very good. So let's say it's a shoulder. So you're just going to have to immobilize really the humerus. Okay? Yes, I could start explaining to you that you're also got to immobilize the clavicle and the scapula, but it's too complicated.
Break the bone.
Keep
You break
it
the bone. You go
The same goes for the leg.
You break
right?
the joint. You go bone to bone.
Okay? Is that clear?
Yes.
So, that, you want to swing him around? That, I believe, is what it says here. And if it doesn't, talk. It should, right. What happened to my,
Do a picture and put it on there.
Oh, pause, please. No, it's not fair, it's late.
As long as we get cold.
This part of the lesson.
Go ahead.
Take a bite in between.
The second you smell that thing.
We'll pause it for this part of the lesson. We'll miss it.
Unless you want to do this lecture next week.
Hopefully there's no head and neck.
Head and neck injuries.
That's the crack.
Okay, large topic, lot to do, okay? Okay, so, quick review, again, as I always do, review of the anatomy. Very important things that every EMT must know. The name of the lower jaw is? Mandible. Name of the upper jaw?
Maxilla.
Maxilla. What is the only moving jaw? The only moving bone
Mandible.
in the skull. Good. Here is the occipital bone. Okay, the occipital bone of the occiput. And over here we have the mastoid process. I'm going to talk now tonight why that is important. All the other bones you should know, you should learn, but it's not critical, not something that you have to know. Guess what you do have to know?
712. I got 4.
Do we know this?
Yeah.
We'll see. New piece of information. The most commonly injured regions of the spine are
Lumbar.
Cervical and lumbar.
cervical and lumbar. Where are they? Cervical up here,
Top
right
of
by
the
the neck, lumbar, lower
Lower
back. Okay, so remember this. This is a new piece of information that I have not yet shared. All right. Very, 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 very brief talk about the nervous system. We did speak about it when we spoke about voluntary and involuntary muscle. And basically, this is how it works. It all comes from the brain. The control of the voluntary muscle is there has to be a message sent from the brain. I want to eat the banana. I want to do something, right? So, the nervous system anatomically is split into 2 sections. We will refer to them from now on as the CNS, the central nervous system, and the PNS, the peripheral nervous system. The CNS, and this is something you must know, contains only 2 things. The brain and the spinal cord. These are the only 2 things that are contained in the central nervous system. This is the sort of thing you would be tested on, okay? So please make sure you know that. Peripheral nervous system
Everything else.
will be everything else to do with the nervous system, whether it's, all the dendrites and axons and all the parts of the nervous system, which are many and complex, and we're not going to get into it. That is the anatomical differences in the nervous system. Now, functional, how does it all work? Basically, voluntary, I want to pick up the banana, right? This is controlled by the somatic nervous system. That's it. That's all you need to know. It's called the somatic nervous system. It controls all those messages that you now understand need to go from the brain to the hand. I want to pick up the banana. I want to put the banana down. All controlled by somatic nervous system. Now, all the other stuff, the part of the nervous system that controls, let's say, the smooth muscle and all the things that go on seemingly automatically, and I use that word specifically, are controlled by the autonomic nervous system. Think of those words very similar. Automatic, autonomic, right? So when you want to digest your food, for example, you don't have to send special messages to your gut that tells you to digest your food. It's seemingly happening by itself. Well, it's actually the autonomic nervous system that's controlling all your smooth muscle, all the processes that are going on in the background by themselves. That nervous system, the autonomic nervous system, is split into 2. Okay? It's split into the sympathetic and the parasympathetic. And I think I mentioned these already. Maybe not. 1, the sympathetic deals with speeding you up. Okay? We call it fight or flight. Fight or flight mechanisms. Anything that causes you to speed up bodily processes, to speed up, to make you run, make you react, to make you jump. Anything that happens like that that needs speed is known as the sympathetic nervous system. The opposite is called the parasympathetic, not the unsympathetic, the parasympathetic, and that is known as rest and digest. Rest and digest, you may read some in certain literature, they call it feed and breed. Same idea, but rest and digest really sums it up better, in my opinion.
So if you
Okay?
want to jump, what's that? What is that gonna?
Again, these are not things you want to do. These are things that happen on their own. They're in the autonomic nervous system. Okay? When we give medications, and again, this is why in medic school we spend a lot of time getting into this. Medications act on one of four things. They can either increase sympathetic tone, they can increase parasympathetic tone, or they can decrease sympathetic tone or decrease parasympathetic tone. That's how a lot of medications work. Both legal and illegal medications. They all similarly work this way. One of these things needs to happen in order for that medication to work. Many medications have absolutely nothing to do with this whatsoever, but many do. And in medic school, you will spend a lot of time delving in and understanding deeper and deeper how these medications work, what they do, how they affect the sympathetic or the parasympathetic nervous system.
What is it adding or taking away? Neurons? What's it?
No, it's adding or taking away from the strength, from the power that one of them has. Remember, they're at an equilibrium. They balance each other out. So if sympathetic is increased, parasympathetic will decrease to balance it out.
So sympathetic will be increased if you're in fight or flight?
Yes, fight or flight sympathetic will be naturally increased. And then there are times when we need a medication to make those processes or some of those happen that are not happening on their own.
So if you were to relax the fight or flight, you do that by either increasing the sympathetic or by decreasing the
The other way around. Increasing the parasympathetic, yes.
Gotcha.
Yes.
But that's
So-
only, those.
So for example, I'll give you one example because I really want to move on to a lot of stuff. If we're treating asthma, so we're going to have the patient inhale 2 different medications. Okay? One of those medications is going to increase sympathetic tone, and the other one is going to decrease parasympathetic tone. The idea is that they're both going to cause the same thing, but just much stronger.
Why is
Okay.
an asthma attack? I mean, the more
I don't want to get into it tonight. Okay, I'm just giving you an example of, again, you will not be responsible to really understand the medications and how they're affecting the nervous system. Okay? This, however, you will be responsible for. So this is a picture of one vertebra, okay? And we know how many vertebrae are there?
33.
33, okay? And the purpose of the vertebrae is to protect the spinal cord. That is its purpose, all right? Just as many bones, purpose of the rib cage would be to protect the lungs, heart, the great vessels, right? Purpose of the vertebrae is to protect the spinal cord. This is the lifeline. This goes between the brain and the rest of the body. When we're checking P, not included, M and S, this is what we're checking. When we talk about neurological deficits or neurological problems, this is what we're talking about, right? Is the message getting from the brain down the spinal cord and out into the peripheral nervous system to the toe, the foot, the ankle, wherever it is, doesn't matter. So this is a good picture. And what you really need to understand is that the spinal cord, which sits right in the middle of the vertebrae, okay, goes all the way right up into the brain, into what I told you, the foramen magnum, very good, the large hole. The spinal cord and the brain have a special covering, special protective coating, and we spoke about the abdominal cavity, we spoke about the lungs, we spoke about the heart. This is the last one that you're going to be responsible to know. These are called the meninges. The meninges. So they cover the entire spinal cord and the brain, all covered by these meninges. Now the meninges have 3 layers. Here are the names. Okay, the way I remember them is PAD, P-A-D. Okay, going from inside to outside. I don't think as EMTs you're responsible for knowing them, but it's really useful to know the names. Now I'll explain why. You have the pia mater, which is the most innermost part of the meninges, the arachnoid, which is the middle layer, and the dura mater, which is the outer layer of the meninges. You should understand that the word, which I'm sure all of you are familiar with, meningitis, right? What is itis?
Inflammation.
Inflammation, right? Infection, inflammation. Meningitis is an inflammation of the meninges. How do we test in a hospital for meningitis?
Shot in the back.
Well, it's not a shot, right? It's a needle in the back. Very good. But now we're going to learn how to say it like grown-ups. It's called a lumbar puncture. Lumbar puncture, an LP. Lumbar. I've heard that word somewhere before.
Lower back.
Lower back, right? Lumbar puncture. Okay, so that's what we're going to do. We're going to take a little bit of fluid out. We're going to talk about the fluid in a minute. And we're going to examine it. We're going to send it to the lab. And we're going to say, hey, is it infected? Or is it the way it should be? Okay? And that's how we're going to determine.
Medics don't do that.
No, we don't do this in an ambulance. This is done in the hospital. Okay? And that's how we're going to determine that the patient may have meningitis. For example, there are other diseases, encephalitis, and other things we can get into, but for now, just want to keep it simple.
So the
meninges.
protect the spinal cord and the meninges.
Yes.
And the brain.
Spinal cord?
Yes.
Those 3 layers are the same material?
Yes.
Just one layer,
Yes,
down?
one on top of the other. They have 3
Same
different
thickness,
names.
Same thickness, same.
Pretty much. Now, the outer one is probably thicker than the inner 2.
And there's nothing in between them, like by the lungs.
Wait, let me explain. Right. What's it called when a woman...
PMS.
Relax. What's it called when a woman gets a special type of shot while she's about to have a baby? Epidural. Dural. Have I heard that word before? Dura mater. Where does the needle go? In the...
Don't get the epidermis.
Okay, well, we're not
But
going
they
to go
give
into that right now.
shots to, they give shots to knock them out also in the spine.
It was okay, it wasn't so bad, overrated.
So like,
numb it
is this,
first,
does,
they put it
does this
in.
spine go through the whole nervous system, right? So they give medication over there to numb the whole entire body, whatever.
That's the epidural.
No, not, there's something else besides epidural.
When they put it in, they numb the area.
Spinal tap is
For
a
surgery, they do before
layman's
surgery.
way of saying a LP, a lumbar
He's
puncture.
a layman, this
They
guy.
do before
No, you're all
surgery or
becoming
something.
medical
He
professionals.
just drives a big truck.
Before surgery they do it.
They can sometimes do.
Anesthesia.
It's an epidural. Okay, so these are words that you've heard. You may have heard or read in a newspaper somebody had a subarachnoid bleed.
Never heard of that.
Never heard of it. Well, now you will.
A snake or something?
You will. No, none of us is nice. But if you read something a little more medical, okay, you may hear about a subarachnoid bleed. Well, now you'll be like, oh, I know. Subarachnoid means below the
Arachnoid.
arachnoid. So that's a very serious bleed in the brain right? And now we know exactly where the bleed is.
How do you get that?
Trauma, usually. Okay? So,
Studying too hard.
now, no, it's never happened. Not documented.
The studying too hard part.
Yeah. So, inside the meninges, we have a special type of fluid that is only found around the brain and the spinal cord. This fluid, for spelling purposes, we call it CSF. Okay? Because the actual name is cerebrospinal fluid. Okay, again, you won't be tested on spelling, but you will need to recognize that word. Cerebro means brain. Spinal, spine. It's very simple. Medicine is really simple.
Yes.
Yeah, cerebrospinal, you know where it's found. If you found that fluid in your toes, there'd be a problem, right? So, very simple. Cerebrospinal fluid, we find this in the meninges, right? Within the meninges, covering the brain and the spinal column. Now, this is what we're taking out when we do a lumbar puncture or a spinal tap, whatever you called it, right? That's what we take out and that's what we're looking at. Now, we are going to get into figuring out what to do if we find leaking CSF in one of our trauma patients. That's where we're going with this. Okay? Yeah, it's bad news.
But how would we find that? We wouldn't be.
Call a medic.
Olive base.
So that's a,
Just gonna get to that.
So, there can be many injuries to the spinal cord. Okay? What you need to understand, what really is critical, is that wherever the injury occurs to the spinal cord, there will be a problem distal to that injury. Alright? Downstream. So, if somebody gets a C1, C2 injury,
The rest of it.
alright, they're done. They're probably going to be a quadriplegic. They're done. Because everything is lower than that. If somebody gets an injury, lumbar, in the L's somewhere, so they may be a paraplegic, maybe the legs won't work, but they'll be able to breathe, they'll be able to talk, their arms will work, stuff like that. So understand this, okay? And it's bilateral. That means
Both sides.
both sides, okay? Somebody gets a spinal cord injury, will be both arms, both legs, or all four. Okay? That's what's really important to understand.
never lose half their body?
Not from spinal injury.
No.
Okay? 2 words you should know. Paralysis. Definition of paralysis is loss of function. Okay? Again, distal inferior to the point. And paresthesia is a numbness or a tingling that also is a neurological problem. Now, you could tell me that sometimes you wake up with tingling. That's because you lay on your arm and you cut off some nerve getting through one thing or another, maybe circulation, whatever it is. When we talk about paresthesia, we're talking about someone was involved in a major injury, a major mechanism of injury, and now they're feeling tingling in their arm or in their leg or whatever it is.
is that a long-term feeling?
It's happening now when you
At
get
the
that
time
you'll
of the
see.
injury.
Okay.
Alright, this is a very big slide. There's a lot on this slide, okay? So settle in. Neurological and head injuries, okay? So the first one on the list here is CSF leaking from the nose or the ears, okay? If there is an injury such that the brain has been affected to a point that there is usually like a basilar skull fracture. The base of the skull has actually been fractured. there may be a leak of CSF. And you may see this. But again, this is a major injury to the head. Usually to the head, and you'll see it coming out the nose and the mouth.
Is it a color?
How will you know? How will you know? Because when you see it, it'll be usually accompanied by blood. You'll put a gauze to stop the bleeding, and you'll see a bullseye where the CSF will look yellow on your gauze and will separate from the blood, which will be red. So you will see yellow and red that's coming out. So if you have a patient with a major head injury, again, you'll base it on mechanism, how it happened, put a piece of gauze there, and check for CSF. If you see that, that's a big problem. Let the hospital know, get moving, head injury, okay? We'll talk more about it. Two things that you can see easily. Battle signs. Battle signs is this bruising here at the mastoid process. And that's why I told you have to know where it is. It's the bone right behind the ear. Okay? Again, basilar skull fracture. There will be blood that will pool over here behind the ears. Again, if somebody has this and they're walking along and everything's good, it's something else. But they were in a major car accident or whatever mechanism, fell off a ladder, pushed out of a window, I don't care what happened to them. But you see this, note it, and know that we gotta get moving. This is bad. The other one are called raccoon eyes. Sorry, raccoon eyes, and this is where you'll see this bruising around both eyes. This can also happen from a pretty simple punch to the nose, and it may not be as severe. We're usually looking at an unconscious patient when we're talking about major trauma.
This happens on both eyes?
Yeah, yeah. All right, posturing, neurological posturing. When a patient gets a severe head injury, okay, they may have neurological posturing. Now, it's not as common as it may seem in your textbooks or whatever, but I have seen it, okay? There are two types. One, where the extremities are in towards the patient and locked. Patient's unconscious, had a major head injury, extremities are in and locked. The other one that you may see is where the extremities are out and locked. They have to be unresponsive for this to be called posturing. Why is this so important? So in Scotland, it's a town in Scotland, in Glasgow, which is a city in Scotland, they devised a way of classifying trauma patients, okay? It's still being used today. You can look up which year it was invented, probably 100 years ago or so. So they say that it was invented for drunk Scotsmen, okay? Why we still use it today, who knows? All right, the AFPU system is way better, way more efficient, okay, and way simpler.
Sure.
Glasgow Coma Scale, I'll talk about it, probably have a slide on it soon, but one of the things is neurological posturing, and these two are like the lowest it can get, okay? These score a 1 and a 2. Okay, so this one in, this one out. All right, they have names. You called decortica and decerebrate. You don't need to learn
So
those.
is there a difference if you see this way or you see that way?
Well, one's worse than the other. I wouldn't worry about it too much. Just, I'm going to teach you what you need to know about the Glasgow Coma Scale. I'm just explaining to you though, neurological posturing is something that you may see. Last time I saw it was a young man in his 30s, fell down a flight of stairs at work, and I was there, and we were working him up, and I said, the EMT came, and I said, okay, you get a blood pressure, I'll start a line, right? So we both needed to open up the arms like this, and it was locked. We couldn't move him, all right? He passed away a couple weeks later, all right? Young man fell down a flight of stairs, it was a number of years ago. So, it's real.
What happens that it's locked?
We're not getting into that.
Brain injury.
All right, brain injury, yeah.
And your
Alright.
body can't move it.
Next, so you got that, could go in, could go out. Decorticate and decerebrate. Those are the names, you don't need to know the names. Cushing's reflex. I may have to go to the board. I don't have a slide on it.
No, you have on glaucoma.
Yeah, but I don't have on Cushing's. Alright, we're gonna go over there. I'm gonna erase some of this beautiful, yeah, you're good, right? So let's talk about Cushing's. Again, this is something that you may see. I have seen this secondary to major head injury, major trauma, serious stuff, okay? Cushing's. Sometimes it's called Cushing's triad because there are three things that occur. Sometimes called Cushing's reflex. Alright? Either way. Three things are going to happen pretty much simultaneously. If you see these three things and the patient had a major head trauma, you better tell somebody at the hospital that's what you're bringing in. Okay? Patient with Cushing's. Number one. First thing you're going to see is anyone know what that stands for? Hypertension. Okay? We can write it in short, increased blood pressure. Okay? Now, pressure will increase. The reason for this is that there is a bleed now in the brain, and the intracranial pressure, which is usually very low amount, is now, there's no space. The blood is bleeding into the brain, it's taking up space, and the pressure is going sky high. So all the pressures will go up. This is called hypertension. Number one, increased blood pressure. At the same time, you will get also bradycardia, which is a decrease in heart rate. This is completely the opposite from what you would know normally like in shock. In shock, you will get tachycardia and hypotension. Okay? This is completely the opposite. Special scenario. This is only when head injury, brain injury. Okay? So, at the same time, you're going to have hypertension, bradycardia. With me? Alright, number three, you're going to have irregular respiration, RR, respiratory rate. It's going to go very fast, periods of apnea, which means no breathing. It's going to go slow. I'm not going to get into it. There are names for the respiratory patterns. We don't need to go into it.
What's the R?
Respiratory rate. Now, for EMT school, we often just say slowing of the respirations. Okay, instead of irregular, which is really what happens, you could say slowing, bradypnea. If you want a good word to figure out how to spell. Bradypnea. Okay, that means slowing of the respiration.
But isn't it the same thing as heart rate?
No, heart rate is pulse. That's how the heart is beating. how fast, okay? So again, a good EMT comes on the scene, sees a major mechanism of injury, sees there was a problem, right away, gets a set of vitals, patient's unresponsive, wow, blood pressure's sky high through the roof, bradycardic, respirations are all over the place. Let's go, get to a trauma center fast, okay, fast. All right, seizures, nausea, these are lesser things. Seizures are very common after a head injury. We'll talk about that in a later lecture. Neurogenic shock. Anybody tell me what that is?
Shock of the brain.
Very good.
9047.
Trauma to the central nervous system. Respiratory arrest, which means what?
Stop breathing.
Stop breathing, right? Where is the breathing center located that tells us to breathe?
Brain.
The brain is a big place. Anyone?
Involuntary.
Nah, can we? Where?
The brainstem.
Okay,
Autonomic.
okay. In the brainstem, very good. Who said medulla?
Medulla oblongata.
Very good. That's correct. The medulla oblongata is what controls breathing.
3 parts of the brain. That's the last one.
Okay, good.
That I remember from 50.
You don't need to remember that, but it's good to know.
And then priapism. I googled it.
You did?
I
Priapism.
didn't need to.
He needs to know about priapism.
What can you say? What is neurogenic shock?
Really?
Not what is it, but how does it? What did someone say before? You
Trauma
said
to
it-
the CNS.
Trauma to the central nervous system. We did that in the shock. You were here for the shock, right? Good. Priapism. This is an uncontrolled, unrequested erection of the male genitalia secondary to a head injury. Okay? Right? It is being demonstrated apparently with a highlighter. Right? It's good that the video is facing this way. Okay? Listen, it's something you have to know. Giggles, very funny, but it's serious stuff. Okay? So know what it is. Alright?
How would one? I'm saying.
We'll show you how to search for it. I'm not joking.
No, sorry.
Okay, again. Pupils.
Wait, what's a sign of neurogenic shock? We talked about that? Signs? I guess we did.
Meet us downstairs in the basement.
I know.
Meet us downstairs in the basement, Charlie.
Moving right along. The only thing that will cause this is a head injury, okay? We can take drugs to cause two like this. We can take drugs to cause two like this. But to get one like this and one like that needs a serious head injury. What's the difference? Oh, because we look in the pupils, we look at every patient's pupils. We want to know, were they doing heroin or were they doing cocaine or were they smacked over the head? That's what we want to know. It's very simple diagnosis. Okay, what have they been up to? All right, or if they have, or maybe they just went to the optometrist. That's always an option, as well as crack cocaine. Okay,
I'm
but
guessing that different drugs cause different dilations.
yes.
Yes.
But head injury will cause unequal pupils. That's what unequal pupils look like. This we call one blown, one could be normal size, or one could be meiosis, which is constricted. You should learn these as dilated and constricted. Okay, you don't need the words at the bottom.
But they will always be the same unless you have a head injury?
Yes. Or you've done enough heroin.
They'll still both be the same.
Yes, they'll always be the same. The only way to get them, here, when I wrote in the list, unequal pupils, that's unequal.
And the only way to have
Head injury, all right? Brain injury, to be more specific. Stroke can do it also, but soon I'll teach you that stroke is very similar to a head injury. But now we're dealing with trauma, not with medicine, okay? How would you treat neurological injuries? Honestly, get them in the back of your ambulance. Make sure the ABCs, that they're breathing, really work on the airway and the breathing, because that's all you can do.
Even
no.
medics, that's basically just the breathing and that's it, or medics have more to do.
Well, we can do more with the airway and the breathing. There's almost nothing we can do in the field.
But it's basically the spine and they have
Right.
to stabilize it.
So, spinal injury, we'll talk about this separately, but extremities. So you understand that you can have a neurological deficit in your arm. Do you understand this?
It would be worse than that.
Yeah? What would be a neurological deficit in the arm?
Nerves.
Doesn't
The nerves.
Right, so you don't feel,
No PMS.
and right, P there will be.
No motor skill.
No M&S. Right. Alright, stabilization of the spine has gone through a lot of changes, especially very recently in the last couple of years. So we're gonna see what slides I have here and what I'm gonna give you the latest protocol. Sometimes with a small child, remember we told you about the sniffing position?
Yeah.
Right, during CPR? So sometimes when the child is supine and you're caring for the airway, it's very hard to get them in the sniffing position. One way to do it is to put a folded towel or sheet between the shoulders. That would help you a lot. So just remember that with a child. Cervical collars are still being used, and we will still teach you how to use them, when to use them, okay? But they are still being used in New York.
You're making that stress because that.
Because other than this is now no longer being used, okay?
Do we need to know this?
Yeah, you need to know that it's called a KED, a KED. I will show it to you in skill night. I'll just show it to you in case you go somewhere where it's still being used.
No longer being used in New York.
Okay,
Right?
head immobilizers are not being used anymore. Backboards are not being used anymore. Alright?
No?
No. So I will teach you what we do now as opposed to what we did back then.
You mean for spinal injuries, not in general.
Anything. They are not being used.
So how do you try this thing that we're doing now? The whole chapter 8 is about backboards.
That was a waste of
What?
minutes. You just unleashed the New Testament.
That's why it's
backwards and I mean.
Not being used. No one is transported on a backboard.
That's it,
ever
I'm
again.
dropping
No,
out.
the way they say is
What does that
they
mean?
take them to the ambulance on the.
You can use it to, you can use a backboard to extricate a patient,
Right.
and then they have to be removed from the backboard.
Oh, they don't. Okay, they don't put the
They don't
backboard
carry
on
a guy in
the
the
stretcher.
Again, they can be used to extricate a patient, means remove them from a scene, from a tight
And then you
space,
transfer
from
them?
an elevator,
To stretch it or.
onto the stretcher, and then it's removed.
Interesting.
We will teach it to you.
Whole chapter 8.
Here is the Glasgow Coma scale. So basically, there are 3 numbers I would like you to know. I should really write it so you can get it there easily. There's 3 numbers for the Glasgow Coma scale that EMT should be familiar with, okay?
What's the Glasgow coma scale?
Yeah, what is it?
It's a way to evaluate drunk Scotch people.
Evaluate neurological status.
GCS. Okay? It's still in protocol, it's still officially being used on every patient. Okay? Don't go crazy about it. Learn these 3 things, you'll be good. Okay? Number 1. Alright, the highest GCS is equal to 15. Number 2, the lowest GCS is equal to 3. Even if you're dead, you still can get a 3. Okay? There is no 0, there is no 1, there is no 2. Again, you want to Google how many years ago they made this system? It was probably a long time ago. All right. Number 3 is GCS equal to 8 ventilate. Okay, it's like a nursery rhyme. GC equal to 8 ventilate. Okay, it's just telling you that if the patient is so bad that they have a GCS of 8 or less, it's not really equal to.
1974.
Yeah, as late as that?
Yep.
So you
That's
gotta-
when it was invented?
Yep.
You have to know what.
I think so. Google.
GCS of less than or equal to 8,
Double check that.
you should ventilate. Okay? Here's how you would calculate it, but really it's on the back of all the ACRs. And if you use a electronic PCR tablet thing, it calculates it for you. You just answer these questions and it'll calculate the number. Okay? This, I believe, has been
Abolished.
abolished. So I'm not even going to talk about it.
Cross it off.
So we're not even going to deal with how you measure the GCS scale?
Yeah, we're really not.
Oh, okay.
You want me to talk? I can talk about it for a minute. So it
goes.
goes with eye, verbal, and motor. These are the things. So eyes. When you walk over to a patient, see how his eyes are open spontaneously? Even though I've been speaking for 3 hours, eyes are all still open. That's pretty good. So your eyes are open, you get a GCS, you get a score of 4 for your eyes.
Oh, good job.
Okay.
Okay? Now, verbal. I say, what day is it today?
Tuesday.
He says Tuesday. Okay. Is he oriented? No. Is he confused?
Yes.
Absolutely.
Inappropriate.
Is he inappropriate words? No, because he said a day of the week. If I said, what day is it today? And he said banana, okay, that would be inappropriate, right?
If you cursed first.
It's inappropriate. It didn't answer my question. If he said, if I say, what day is it today? And he goes, right? That would be comprehensible. If he says nothing,
He already gets one.
he gets a 1.
Because his eyes were open.
No, his eyes are open, he gets a 4.
I'm sorry.
Points for doing
You're
that.
adding it together.
So
Hello,
what-
1, 1,
why
and
is he
1.
getting 1 for that? That was part of
Nothing.
the,
Look,
that's part of
eyes.
the minus the 3.
Eyes, nothing. 1.
Right.
What do you
It's
got?
It's like getting.
The highest over there is 60. Oh, it's
15.
15. 4.
He's on my corner.
Next, motor response. Raise your hand. He does it.
Do it.
He does it.
Oh, I did.
Right. Okay. He obeys commands. He gets a 6. Where does it hurt? Raise your hand, nothing. Where does it hurt? Right? Does it hurt here? And he pulls his hand away from me. Or he pulls my hand away from him. That would be withdraws from pain. Flexion. Flexion.
Punches you?
Decorticate.
It's out.
Extension. Decerebrate. No movement.
3.
Right? That's how you calculate it. But don't make yourself crazy about it. Learn these 3 things. Okay. There's very little here that.
So you guys come into the hospital telling him what number?
Yeah.
Every
guess
patient?
you
Only
would
No, most patients are 15s or 14s. They don't care. But if you got someone 8 or less,
They have to
you
know.
better know, and you better call them before.
They have a chart in the.
So you're doing a GCS every time?
Every patient.
Really?
Every patient with a
quick,
brain
though.
injury, every patient.
Every patient.
Usually over 8.
So then why does it
Having a
matter if
conversation
they're
with them, they
over
have a 15.
It is important. Once they're over 8, you don't have to.
There's 2 questions already.
Again,
99%
If you're
of
talking
patients
about the
are
jet game with them, they were 15.
again, if you're doing a paper ACR, all New York State ACRs has the GCS numbers on the back with the questions. If you're doing it on a tablet, it says eye-opening, spontaneous click,
Oh, okay.
responds motor, click. Don't worry.
You don't have to know eye injuries?
No.